Welcome to Season 4 of Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology and provided at no cost to medical providers. Derms on Drugs is where cutting-edge derm meets hit or miss comedy. I'm Dr. Matt Zires from Doc's Dermatology, and each week I'm joined by my residency buddies, Dr. Laura Ferris from the University of North Carolina and Dr. Tim Patton from the University of Pittsburgh, and we use our 70 years of combined derm experience to discuss, debate, and dissect the hottest topics in dermatology. It is everything you need to know to be on the cutting edge of derm, and you'll actually have some fun listening. New episodes drop every Friday on Scholars of Medicine, Apple Podcasts, Spotify, and other major podcast platforms, and I highly recommend that you download the Scholars in Medicine app to access the full podcast video archive, explore the best derm educational content out there, real pharma, independent coverage of all of dermatology, and an amazing core curriculum for newbies to the field, and cutting edge, the latest of the latest on new drugs if you've been in the field for a long time, all supported by an amazing AI clinical consultant called Ask Simon. And I am so excited this week. We've got a topic for this week that is so outside of the norm for everything that you usually hear in the world of derm. We're going to be talking about male genital disease. We've had episodes talking about vulvar disease before. So today we're going to be talking about penile disease, and we actually have a guest coming from the UK. So we've got Dr. Christopher Bunker from University College in London, who runs a male genital disease clinic. Dr. Bunker, welcome to the show.
Thank you very much. Great to be here. Nice to meet you all like this. I wish it was in the flesh, but it can't be like that.
And before we kind of get into talking about male genital disease, how did you get into this as a topic? I think most dermatologists in America, if you could ask them, would you like to ever see anybody with male genital disease? They would say, no, I would be very glad to never see anybody ever again. So what got you into a specialty that most people would actively like to avoid?
Well, I started as a general dermatologist, as most people of my generation do. I'm 70 years old now, and I've been a clinician in central London, big teaching hospitals a long time. Most of your work was general stuff. I felt sorry for men, actually, because we had vulval clinics going for a generation in the UK and in London. I had a big HIV practice in the early days of my career, so I met a lot of men. And I realized that men, I think, were being disadvantaged, whatever their sexuality, actually. And I was doing a monthly HIV clinic, and I felt that there was some mileage in trying to help some of the men with these problems. So I also had realized that some of the things that I've been taught and believed in my training were wrong. For example, about the pathogenesis of Lichen, sclerosus, Zoo's disease, and so on. So I set about systematically trying to demonstrate, for example, that Lichen sclerosus is not an autoimmune disease. And the only way you can do that sort of research, actually, is have high volume clinics, because these things aren't common. So you've got to have lots and lots and lots and lots of patients. And I must have seen tens of thousands of patients with Lichen sclerosus now, and that means you can do meaningful research. So I'm proud of that. I think we've made a difference. But, I didn't leave medical school saying I'm going to concentrate on penises. And, my daughters grew up going into my study when they were little girls and teenagers with pictures of unhealthy penises all over the floor and on the desk. To watch the amusement of my colleagues and wife and daughters, I've become a big prick man. But I also deal with little penises too.
That's all right.
See, I think this is funny because I went to Catholic school all through basically all of my education. And I think that pictures of male genital disease was our major sex education in Catholic girls' school. Basically, they're like, here's what might happen if you have sex. And that was pretty much what we learned. So maybe I could have become a genital disease expert too.
That'll be called child abuse now, and all those nuns and bishops would have been defrocked, I hope.
This is true. This is true.
All right, so Dr. Bunker, let's start with, we're all very comfortable. And we're going to talk about one of the papers that you recently published, kind of an overview of penile cancer. But before we get there, lichen sclerosus is obviously one of the big precursors to penile cancer. Derms here in the U.S. are very familiar with female genital lichen sclerosus, male lichen sclerosus. Just kind of take us through some of the basics of it to begin with. Primarily the glands of the penis, or the entire penis, circumcised versus uncircumcised. How does it typically present? So just some of the very basics, as it's not something that a lot of us see a lot of.
Yeah. I think you're right. It's not that uncommon. It's probably commoner than people think, because it can be very subtle in its symptoms and its signs. And one of the fascinating things about it to a clinician is that you can have people with really florid symptoms and not much to see, and really florid signs sometimes and not much in the way of symptomatology. But the critical issue usually for young men presenting is what we've termed male dyspareunia. In other words, sex is difficult. When I was at medical school, dyspareunia was exclusively a term you found in gynecological textbooks, and it was the preserve of women to have uncomfortable sex. But uncomfortable sex is probably the pressing symptom in young men presenting with the disease. But men will find it difficult to concede that symptom. It sometimes has to be elicited. In the last few generations, most of my trainees, you call them residents, we've just started to do that, have been women. When I went into dermatology, it was mainly a male specialism. Now it's almost female. And, a young man in my clinics would find it very difficult to say to a drop-dead gorgeous young resident that sex isn't going well, so unless you ask. So male dyspareunia is the predominant thing. I think that if someone says to a physician, a man says to a physician that life is uncomfortable, sex is difficult, the first thing you should be saying is, does this patient have lichen sclerosus or not? And it should be the onus on the physician to exclude it. But let's go back one step, if you will. Lichen sclerosus does not happen to people who've been circumcised at birth. Full stop. And that's the fundamental observation around the argument that it's about occlusion of microdrops of urine. Because if you've been circumcised at birth, however dribbly you are, and we're all dribbly, God did not give us a proper tap or valve at the end of the hose pipe, unfortunately. If you go to a garden store in the United States and buy a hose pipe for the garden, you've got a tap and the wall. You've also got a tap at the end of the nozzle across the lawn, haven't you? But unfortunately, we urologically, we've not been plumbed like that. So if you dribble after peeing, microdrop, you circumcised, you don't notice it. It's a drop on your underwear. You don't even see it. It's not a flood. So it's not a ghastly stain, but a tiny drop with occluded tissue, then chronic irritation of a delicate epithelium follows. So the fundamental observation is that you've got to be uncircumcised. So I actually say all men with a foreskin should be suspected of having lichen sclerosus until proved otherwise.
I have to jump in for 1 second there and ask this. So it's always interested me that, so in the US, and I imagine in the UK, there's some controversy over circumcision. So, it's primarily obviously still done to infants, but there are lots of people who say, oh, we shouldn't be doing it. And to me, as a dermatologist, I've been surprised at the number of disagreements I've had with both other physicians and with lay people, in whom I've said, look, like, getting circumcised largely eliminates your risk for numerous male genital issues. From a medical perspective, it makes sense to me. And normally, whenever I've said that, I've been thinking about HPV, because most of the bad cases of HPV I've seen have been in circumcised men. It really hadn't occurred to me that lichen sclerosus, obviously Zuhn's balanitis, I was aware of, but that's fascinating. And and I know that you're primarily a male genital disease specialist, but I assume that pathophysiologically we should be thinking of male and female lichen sclerosus similarly. And I've always heard the vulvar specialists kind of repeat the idea of, oh, it's an autoimmune disease, and no, urine doesn't have anything to do with it. And I'm always like, but then why is it little girls and older women, the two groups of women who have low grade incontinence, why are they the only ones getting it? It never made any sense to me. So it's fascinating for me to hear.
No, it's never made any sense to me. I mean, I don't do vulval clinics, but I think I'm beginning to persuade my colleagues in female genital disease the merits of the argument. But the trouble is, we've all been to medical school, we've all done our training, we've all practiced. If your boss tells you something, it's an autoimmune disease, or it's in the textbooks, an autoimmune disease, it's in the exams, it's an autoimmune disease, that's what you trot out without actually listening to the symptoms and observing what's in front of you. And it's a near clinical lifetime over listening to patients, observing the pattern, particularly of lichen sclerosus and some of its variants. That it's not molecular science, which is probably why I won't get a Nobel Prize or fellowship of the Royal Society. But you've got to be a molecular biologist now to get those things. But it's staring you in the face. It is not an autoimmune disease. It's due to occlusional contact of urine with a susceptible epithelium. And, what most of the research I'm doing now is about what are the epithelial susceptibility factors and why doesn't everybody with a foreskin get lichen sclerosus? Because they don't. That brings me back to where you were going, really, was why don't we say as in our societies everybody should be circumcised at birth? Well, the thing is, if you look at the serious diseases like lichen sclerosus and penile cancer, with PEIN in between, the prevalence of these diseases in our society is not high enough to justify circumcising everybody at birth. You'd be circumcising hundreds of millions of people, probably 1 billion or so people, unnecessarily, to prevent bad STDs and the disease I'm interested in, lichen sclerosus and penis cancer. You mentioned Zuhn's balanitis. Well, we've done some painstaking work to show that Zuhn's balanitis does not exist and has never existed. If you look at Zuhn's original papers, which we've done, and you read the clinical descriptions, you read the histology, and you look at the pictures, which unfortunately are black and white, those patients had barn door lichen sclerosus. And we've been through the 104 or 5 papers that have been published on Zuhn's balanitis since 1952, and Zuhn's original stuff, they all had lichen sclerosus, all of them. So florid zoonoid inflammation is a facet of lichen sclerosus, and it sometimes, in fact, often gets in the way. And of course, you say a clinician has read about it in textbooks, seen a few cases, boss said Zuhn's balanitis, you do a biopsy, and you get zoonoid inflammation. So, yeah, there we are. We've got Zuhn's balanitis. But it's not. They're all lichen sclerosus, every single one of them.
What do you make of the anti-ECM1 antibody picture? Is that a secondary phenomenon?
Yeah.
Is that like...
Yeah, I don't know if you're familiar with the literature, but one of those papers is actually from my group, where we demonstrated EC1 antibodies and lichen sclerosus. But the only explanation that fits with the facts is it's an epiphenomenon that because of the chronic inflammation, the basement membrane zone is exposed and antibodies are created to ECM1. They're not directly pathogenic in the same way that they are in... I forgot.
Right.
Very rare genetic disorder with a ECM1 mutation. Anyway, lichen sclerosus, ladies and gentlemen, does not exist. But Zuhn's balanitis does not exist. You say, that's Zuhn's balanitis. You look carefully.
That really killed your research.
You look carefully, you'll find lichenoid inflammation and scarring and so on. But of course, one of the reasons why the diagnosis is perpetuated in the textbooks, because it either gets better with strong topical steroids, like lichen sclerosus, or it gets better if you're circumcised, like lichen sclerosus. So,
do you recommend that adult men who have lichen sclerosus get circumcised as adults then?
I think that you need to make a confident diagnosis, and then they need a trial of ultra-potent topical steroid treatment and advice about the causation, which is urine. And if they don't respond, or if they respond and then flare early or floridly, then they should be circumcised to obviate the cancer risk. When I started all of this, most urologists in Britain did not believe that lichen sclerosus was a precancerous condition. And one of the battles I have won with British urology is that now most urologists do acknowledge that lichen sclerosus is precancerous. And in the literature, the highest published rate of cancer with lichen sclerosus is 12.5%, i.e. 1 in 8. The lowest reported rate in the literature is 0%, which is all my series of patients, because we diagnose them, we treat them. If they don't get better, they get circumcised. But the average rate is about 4 or 5%, which sounds right, because that's the published rate for women, where there is not the equivalent of foreskin circumcision as a backstop to the failure of steroid treatment. So, no, I don't advocate that every male with lichen sclerosus, whatever their age, gets circumcised. But if they fail ultrapotent topical steroid treatment and barrier protection, with the advice about avoiding urine, then yeah, they should be circumcised to obviate the very significant risks. And I don't know if you're familiar with the epidemiology of penis cancer, but it's the same in the United States as it is in Britain. The age incidence of penis cancer is like this. That bit, which is near vertical, is in your 80s and 90s. So if you diagnose and treat lichen sclerosus when people are 40 or 50, and make sure they are cured definitively, whether it's by medical treatment or circumcision, then you're doing them a big favor.
So what is your typical regimen? So I guess first, do you think every case requires a biopsy to confirm the diagnosis?
Absolutely not. No case needs a biopsy. It's a clinical diagnosis. The right symptoms, the right signs, is a clinical diagnosis. If you've got a case where you're not sure and try to do a biopsy, you'll get non-specific findings. It's a barn door clinical diagnosis. Biopsy is reserved for suspicion of penile intraepithelial neoplasia, which can, of course, be present at presentation of the lichen sclerosus. So absolutely not. It's a clinical diagnosis. And having made the diagnosis, then people get given, in my regimen, is a month, 4 weeks of twice daily clobetasol propionate. We call it Dermovate in the UK. But they need to make sure they squeeze and massage the last few drops of urine out after peeing. They need to use a barrier preparation, a simple...
What's your favorite barrier?
Well, we've got brand names in the UK that you may not have. We have a thing called Epaderm, which I think the trouble is in the United States, you've got a steroid called Epiderm. But anyway, I use Epiderm. We've got things like Hydromol. You could just use simple Vaseline, except it's very sticky. It doesn't, wash off. Then people need to trim their pubic hair, because hair gets coiled round inside the foreskin and adds to the irritation. And people need to avoid soap and shampoo and shower gel and the like. So they get a month of that. If they're not 95 to 100% better after a month, then I tell them they should be circumcised. If they are very much better, and about 50 to 60% of them will be 95 to 98% better, particularly if they've observed the adjunctive advice, then I say, you just carry on now, no more steroid, barrier preparation, squeeze out the urine, see what you're like in 3 months. And most of those will go into long-term, maybe even lifelong remission. Relapsers, relapse early or floridly, then they should be circumcised, in my view. And if you paint the picture the way that I do to patients, I have very few people who won't follow that advice.
Wait, I'm sorry, I was busy looking up Epiderm cream. Wait, so twice a day, clobetasol, do you use cream or ointment?
That's a subjective judgment I make depending on the presentation. Many people are presenting a more moist, thrushy presentation. Other people are presenting a more erotic, dry presentation. The dry guys get the ointment, and the wet guys get the cream. And it's 90% of the latter and 10% of the former. And that's something else, a point I would like to make, if you'll allow me. An uncircumcised man that gets thrush has lichen sclerosus. Primary candidal balanoposthitis, like Zunes, does not exist in men unless you've got diabetes. You guys look quite young to me, but in the early days of the HIV epidemic, I qualified in 1981, it's the first case of it. These people, they have thrush all through their mouth and down their esophagus. You never saw candidal balanoposthitis in the HIV people. It's only diabetes. Otherwise, it's lichen sclerosus. So a history of thrush in a man. They've got a moist prepuce. If you look carefully, the thrush will get better with some treatment. The lichen sclerosus signs may subside, but they've got lichen sclerosus. So the moist ones, they need some Dermovate. And the reason for just going off on that tangent was because if they are very thrushy, then I also give them something like fluconazole tablets, once a week. But the thing is that this is really important. The candida is secondary to the balanoposthitis. It's not a primary disease. It's not a primary affliction in men. And the battle I have not won in the UK is with my colleagues who do venereology, who still believe that candidal balanoposthitis is a primary sexually transmitted disease in men, which it's not.
So do you think of Zunes, what we've called Zunes, as being the early acute onset phase of lichen sclerosus, or is it, it could be any phase of the disease? They can have lichen sclerosus for a long period of time, then when it gets acutely inflamed, looks like Zunes.
Yeah.
Is it
the latter, sir? The latter. I think it's it can complicate it at any time. The thing about Zunes is it can be much more florid than the lichen sclerosus. And what's fascinating, and I'm trying to get some money to do research on this now, is which is chicken and which is egg. Which comes first, the lichenoid inflammation or the zoonoid inflammation? And as you know, lichenoid inflammation is T cell driven, and Zunes is B cell, plasma cell inflammation. So you've got a lot of immunology going on in lichen sclerosus, but it doesn't mean it's an autoimmune disease. Getting funding to do research is extremely difficult, so I didn't need to tell you guys. And, you can get a bit of money, perhaps, if you're lucky, with penis cancer and pre-cancer. But you start to say to a funding body in the United Kingdom, you're interested in the differential pathways to B-cell inflammation, T-cell inflammation in the penis of men with so-called Zunes balanitis. You've lost people before the ink's dry on your grant application. But you asked me earlier why I got interested. I'm a clinical academic. I had a great scientific training. I did a research degree when I was younger. You probably don't know this, but in the UK, an MD is a degree which is senior to a PhD. You do a 3-year doctoral thesis. You don't qualify MD. But anyway, I did mine on inflammation way back when I was in my late 20s. So I've always wanted to do research, and I was interested in lichen sclerosus because if you think about it, the whole of skin biology and pathology is in lichen sclerosus. It's inflammatory, and it's got B cells and T cells. It's got scarring and fibrosis, and it's got precancer and cancer. And so from an intellectual point of view, there's something in it for everybody. A lot of lessons to be learned. The epithelial susceptibility thing we're trying to get money for, and the route to cancer is fantastic, understudied. I'm sorry if I sound too evangelical about it, but penis cancer is squamous carcinoma of the penis. It's a skin disease. It's not a urological disease at all. It's a skin disease. Yet, if you separate out the HPV-driven bit, which is about 85%, and from the lichen sclerosus-driven bit, which is 15%, of course, in life, HPV is common, lichen sclerosus isn't. So you find people with penis cancer, precancer, who've got HPV and lichen sclerosus. But if you get rid of the HPV lot and just the lichen sclerosus lot, and here you've got to have really high volume clinics to get those patients, and we've got them in abundance. What you've got is a unique pathway to squamous cancer that isn't HPV, because you can control for that right to the nth degree of molecular biology. And it's not UV light, obviously. It's more akin to, we think, chronic inflammation or scarring like you see in Marjolin's ulcer in the skin, or like you see in epidermolysis bullosa, or like you see in chronic arsenicism. And it's not smoking either, by the way. But so it's for the true skin biologist who's interested in pathogenic pathways. What is it about lichen sclerosus that creates squamous cancer when it's not UV, HPV, and all the rest of it? So intellectually, it's fascinating too. Quite apart from getting men back in the sack.
I mean, that's how you should.
A question, sort of moving on. So I had looked over with interest your review paper, Penile Cancer, a Preventable Cause of Death in Elderly Men, just recently published in British Journal of Hospital Medicine. And I know y'all are talking about penile cancer not related to HPV. But I was really fascinated by, you talked about, there was a meta-analysis that looked at studies that looked at adjuvant HPV vaccination in patients treated for HPV-related disease. And so, I was always taught the HPV vaccine prevents infection. It doesn't work once you're already infected. But in this study, you found that HPV vaccination, or that you quoted the study that found the HPV vaccination was associated with reduction in CIN recurrence with an odds ratio of like 0.28 to 0.45. Were you surprised by that? And is this something that you use in your clinical practice?
Thank you. I wasn't surprised by that. We don't have the numbers of patients with PEIN, like there are, sadly, there have been patients with CIN in the world to do the research. And neither the people that make the vaccines nor governments nor charities want to fund a longitudinal study of HPV vaccination in PEIN against whatever control you could come up with. And of course, you'd have to go for decades, because I told you, the penis cancer's in your 80s and 90s when it really bites. But if you look at all of the evidence in toto, indirect evidence, post-exposure HPV vaccination is arguably a beneficial thing to do, because although you might say the horse has bolted, to boost host immunity, to try to keep the HPV in the box, in the cell, rather than creating molecular or histological or clinical disease, has to be arguably a good thing. I mean, there's accumulating evidence that just about anyone who's ever had sex with anyone else has got genital HPV of different types. And what determines whether people express that molecularly, histologically, or clinically depends on their immunogenotype. And fascinatingly, very little work has been done on immunogenotype in cervix cancer and CIN, fascinatingly. Yet, this disease is HPV 16 and a few other types in most people. But some girls, tragically, before vaccination, would get galloping HPV cervical disease and die in their 20s. The same virus. Others just have a bit of scrape and whatever and had a perfectly healthy life. And this is all before vaccination. So there's a broad spectrum of, I think, immunogenotypic propensity to how you react to HPV. I think once you've got HPV in your genitals or anywhere else, you never get rid of it. I don't think you clear it. I think it's molecularly detectable forever. And therefore, because you must have all have had patients, people happily married for years and years and years, and you believe them that there's been no sexual infidelity at all. And then the male or the female comes in one day and they've got some warts because they've been put on some steroids, or they've just been a bit run down. And they've had no other exposure to HPV except premaritally. And so it's been there, and then something happens and exposed. Those are benign types, doesn't matter. I think one of the things in medicine that's been miraculous, I don't do female disease, but the data now around about the impact of HPV vaccination on human health is just astonishing. I don't think we've had it in the UK. There's a paper just a few months ago. No deaths, no diagnosis of cervix cancer for a year or so. It's incredible.
Wow.
Wow. Wow.
And do you
Right,
think
Pat,
there's any?
The sin we made in Britain when the vaccines came out was not vaccinating boys as well. Quite apart from dealing with male disease, it would have reduced, affected the herd immunity. And in the United States, it was available to boys and licensed for boys, but you have other inequalities in your health system. I've only got daughters, and I paid for them to get vaccinated when they were preteen because I could see the way the research was going. If I had sons, I would have done the same thing. But it took me and others a decade or so to persuade our government the errors its way. So we only started vaccinating boys on the state pre-COVID. So a bit of time to wait to see all that kick in. If you're interested in these arguments, I wrote a paper in The Lancet in about 2018 on extending the benefits of HPV vaccination in men. I don't know about you people, but I've had myself vaccinated against HPV because I've been treating people with warts ever since I qualified, nearly 50 years, and creating with cryotherapy a plume. And I smoked until I was 35, and I've been on immunosuppressive medication for seronegative rheumatoid arthritis for 10 years. So really, penis cancer is a nasty disease. I don't think I'm at risk of that. But oropharyngeal HPV-driven cancer is horrible. So I and many colleagues like me in British dermatology have been getting ourselves vaccinated, clearly post-exposure, just as a general sort of blanket protection against reactivated HPV disease in our oropharynx.
Wow. That's
Pat,
something for all our U.S. dermatologists to think about is should we be considering, those of us who are too old to have been in the vaccine wave, should we be considering getting the vaccine? That's really interesting. I think it'll also be interesting to follow the data over the years, like we've seen for cervical cancer. We're starting to get data for head and neck cancer now. And then probably as the population ages, it's going to take a while to get the penile cancer data, but really interesting. Yeah. Maybe we should be looking at dermatologist HPV positive malignancy too.
Yeah. I touched on something there, if I may, ladies and gentlemen, where I think dermatologists are not being as sharp as they should be, is about the risks of penis pre-cancer and cancer in uncircumcised men who we put on biologic drugs. We're not smart on that in patients who are on immunosuppressive regimes for transplant. We all know about cutaneous cancers in kidney transplant, lung transplant patients. But the number, I see a few every year, and no one's ever asked them, have you been circumcised? No one's even looked at their penis. They're getting penis cancers. And we really don't know the story with the biologics. Of course, the newer biologics are much more targeted and probably aren't such broad spectrum immunosuppressants, maybe don't have any bearing on HPV reactivation or not. And in the US, like in the UK, the HIV management has been transformed by the drugs. But we know that anal cancer and penis cancer, the risks are not reduced by going on antiretroviral drugs. The risks appear, we haven't been able to prove this. I've just published a few exploratory papers about this in HIV. It looks like the risks of getting penis cancer, anal cancer in HIV depend on your nadir, i.e. how immunosuppressed you were at time of diagnosis, your CD4 count, viral load, and so on. But just adequate treatment doesn't reverse the risks. And the anal cancer risk is nearly as high as 100 times. And the penis cancer risk is harder to quantify, but it's probably at least 10 times. So there's an argument, which isn't very popular with a lot of my HIV patients, that anyone with HIV disease should be counseled to very strongly consider circumcision. Because once you're circumcised, your risk of penis cancer plummets, whether it's related to HPV or lichen sclerosus. Anyway, that's a very controversial thing. But just for derms generally, immunocompetent people, ask them, are you circumcised? Have you looked at your penis? Did you have HPV? Let's have a look, fella.
Interesting. All right. Before we sign off, Patton, you have any final comments or questions for Dr. Bunker?
No. Very interesting conversation. Learned a lot.
All right. Well, Dr. Bunker, I want to thank you for being on. And before we go, I have to give all of our listeners my favorite pearl for dealing with what I call concern for non-observable problem of the male genitalia. So, the guy who comes in and, oh, but that's abnormal. That's abnormal. What is it? And you're looking at it saying, I don't see anything. The best line that I have ever come up with is this one. So, sir, that's a normal finding. That's a pearly penile papule. It's a this, it's a that. And no, but it's not normal. It's not normal. Sir, I have closely examined thousands of male penises. And I can tell you based on that extensive experience that this is a normal finding. How many male penises have you closely examined? That usually gets them to stop pushing to claim that it's an abnormal finding.
That's great. It's a great story, and I use a slight variant of that. But the other thing is threaten them with a biopsy.
Some guys are strange. They're like, yes, I need to know. And it's like, okay.
All right.
Well, I hope one of the messages we're going to get across is the biopsy doesn't necessarily help you in penile disease.
Right.
No.
I always say sometimes when people have had a behavior that they're concerned about, you can become focused on this, because I think 75% of the time when I see this, the man has done something that they are maybe worried about or concerned about. It usually follows a behavior if I push hard enough, but maybe that's not a fair
You're absolutely right, and that happens. I call it. Do you call them stagnites in the United States? Stagnite syndrome. People have done something they didn't.
Oh, bachelor night.
Weekend in Las Vegas, I think, is the equivalent in the United States.
Yeah.
Mm-hmm.
We normally do trivia at the end of the show. And here's the rule. You have to let Dr. Patton finish reading the question.
Okay.
And then as soon as he's done reading the question, the first person to call out the answer is the wins that question. And we typically do 3 questions.
And there's 4 of us in this competition. Is that right?
Well, Patton's not in the competition because he's reading the question. Me,
yourself, and Laura here.
Yes.
We're it.
Okay.
And, all right, let's hear him, Patton.
Yeah, and it is male genitalia, just in pulp culture and general other things. All right, ready?
Yep.
Number 1. Chuck Berry's only number 1 hit was this novelty song released as a live recording in 1972.
My Ding Dong a Ding.
Oh, that's close enough. I'm giving it to you. It's My Ding-a-Ling.
Ding-a-ling.
Yeah.
Oh, Dr. Bunker, that's an American song. I can't believe Ferris and I are letting down the US of A.
I was only 1 when it came out and you weren't born, so I'm going to give us a pass on it.
What's my prize?
Wait, there's 2 more questions.
Tell all your friends, yeah.
Bragging rights.
Yeah, bragging rights. The recording that actually went to the number 1 was recorded in London. So the crowd participating and things like that, it was a London recording.
Well, I didn't get it. I didn't get the title completely right, so I'm happy to share the prize with others. But I remember it as a teenager.
We'll give you 0.5 points going in. That usually wins. All right.
How many?
Number 2.
How many points do I need to get accreditation to practice in the United States of America? Or
that's a tough one.
Yeah, that's hard.
Ferris would probably give you a residency position if you want to come and repeat it.
I might give you a residency position at the University of North Carolina. We could debate that.
Right. 0 points, you get that. All right. Number 2. In an early scene of what 1998 movie does Ben Stiller's character have a horrendous accident involving the zipper on his pants?
There's something about Polly.
Something about
really
Mary.
Close.
Well, there's one where he's his parents want to get out his foreskin from his circumcision, and it ends in a fondue pot.
There's something about Mary. I'm giving that to Ferris.
Oh, I was so close with there's something about Polly. That's not, there's a different Polly one.
All right. Yeah. Along comes Polly.
I think fondue is forever ruined for me, though, now that I've heard that other story. I'm glad that I heard this after I went to Switzerland, but go ahead.
Number 3. What is the name of the traditional British steamed suet pudding studded with dried fruit, usually currants?
Blood pudding.
Nope.
It's called spotted dick.
It is called spotted dick. and it is like, it was named that way before that was ever slang term. It was just, they think it was maybe how they pronounced dough way back in the day, and the GH was more of a hard sound, and then it evolved into spotted dick.
I think
But it
it's
preceded the slang, but the name has stayed. Although I've heard some people call it spotted dog, or
Yeah,
do
I think,
most people say spotted dick?
Some cooks in their recipe, they chuck in some sultanas or raisins.
Yes, raisins, currants, right.
And
That was my understanding.
They're the spots in the dick.
All right. Another thing I won't be serving at the holidays for dessert. Thank you.
It looks delicious with a custard sauce.
I'll
looks
take
delicious.
your word for it, and that makes it slightly even more disgusting sounding. But thank you.
All right. All right. So
Dr. Bunker ran away with that one.
did run away.
Yes, you
1.5
win,
points.
Dr. Bunker.
Agree.
Right, so
You got your residency spot.
do I get a faculty position now?
Well, we'll talk. It's going to take a few more questions.
Well, Dr. Bunker, again, thank you. I want to thank everybody for joining us this week. Hope you're going to join us again next week. And until then, I'm Matt Zyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.